So hi, everyone. My name is Mark Stebbin. I'm the president of STI Canada, and it's my pleasure to welcome you to this webinar of the International Union Against STI Canada branch. And today we have a unique opportunity to meet a person that will most likely bring questions to your workplace. So it's the title of the webinar is Advancing HIV and STI Prevention: Are Strengths-Based and Sexual Pleasure-Focused Approaches to Sexual Health Missing Pieces for the Prevention of STI and HIV. So the webinar objectives are differentiate strengths-based approaches to clinical approaches in advancing stigma reduction in HIV and STI prevention, integrate sexual pleasure-focused approaches into HIV and STI prevention programming, and apply the principles of sexual health enabling environments for the prevention and management of STBBI. And for this webinar, I'm very happy to introduce Carmen Loggy. Carmen is a Canada Research Chair in Global Health and Equity and Social Justice with marginalized populations. She's a professor at the Factor Inwentosh Faculty of Social Work at the University of Toronto. She's adjunct professor at United Nations University Institute for Water, Environment, and Health. And she's also research scientist, Center for Gender and Sexual Health Equity, adjunct scientist, Women's College Research Institute at the Women's College Hospital. So maybe you've also heard her on her podcast that you can find where podcasts are, and the podcast is about Everybody Hates Me. Let's Talk About Stigma, with more than 15,000 downloads. So please, Carmen.
Thank you so much, Mark, and thank you also, Greg and STI Canada for having me. I'm going to share my screen and say thank you for spending your, well, I know you might be from all across the country, so thank you for spending this moment with us today. As described, I'm going to really focus just on exploring strength-based and sexual pleasure-based approaches to HIV and STBBI prevention, and what are some possibilities when we think about that. And you can follow me on Twitter, just at my name. So there are three major parts of the talk today. The first, I'm just going to give a brief snapshot into how I'm conceptualizing sexual health. The second, we're going to look at strength-based approaches, and then we're going to move into pleasure-based approaches to HIV and STI and sexual health. So first, what do we mean when we're talking about sexual health? I'm sure you're all experts, but I just want to make sure we're starting from the same page. So really looking at the WHO operational approach to sexual health, and they describe sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. So you see pleasure is already in the definition. And there are four components, which I'm going to be showing in the next slide, which include comprehensive sexuality, education, and information, sexual and gender-based violence, prevention, support, and care, preventing and controlling HIV and other STIs, and addressing sexual function and psychosexual counseling. And if you're not aware of this figure, it's available in the report I mentioned earlier, as well as Rob Stevenson et al.'s article in The Lancet. And the blue is those dimensions of sexual health I just noted, and they're intertwined with these dimensions of reproductive health in orange. And at the top, which is important, you see it's encircled by cultural and social norms around sexuality, gender and socioeconomic inequities, human rights, and laws, policies, and strategies. And the foundation in gray, which is rooted on, I'm going to go into next. So these foundations include cultural and social norms around sexuality. So considering intersecting forms of stigma, including racism, sexism, HIV stigma, sexual stigma, LGBTQ stigma. There are rooted in gender and socioeconomic inequalities, human rights considerations, and that's particularly true by a lot of people affected by HIV and STIs, including people living with HIV who experience criminalization with HIV non-disclosure, racial profiling, sex workers' lack of rights, criminalization of drug use. We could go on, and laws, policies, regulations, and strategies. So that's the foundation of which we're talking about sexual health today. And as I promised, we're going to get into some fun things, including strength-based approaches to HIV, STI, and sexual health. So what do we mean when we're talking about strength-based approaches? I'm just providing a high-level overview of these concepts today. You could spend years studying these topics, so I'm just giving some snapshots. 3 snapshots I'd like to present regarding strength-based considerations when we're thinking about HIV and STBBI prevention and care. The first is sex positivity. The second is intersectionality. And the third is how we can consider leveraging the strengths in communities for prevention. So what is sex positivity? There's not one definition. So I'm providing one definition, but if you look in the literature, there's a lot of different ways that sex positivity is understood. This one definition describes a sex positive perspective, encourages agency in sexual decision-making, and embraces consensual sexual activity as healthy, something to be enjoyed without stigma or shame. It embraces sexuality as a human right. And so, this does stand in contrast to more medicalized models, which can inadvertently be deficits-based if they're only focusing on pathologizing and diagnosing sexual health problems and sexual risks. So if the only time we're talking about sex is as a risk factor, as a danger for disease or violence, that's not a sex positive approach. Sex is often stigmatized. I talk about this all the time in my work on stigma. A lot of the roots of sex work stigma, homophobia, transphobia, HIV stigma, STI stigma are rooted in the fact that we stigmatize sex in general. So we do not live in a sex positive society. I don't know where there is one in the world. There are some that are more sex positive than others, but in general, sex is often stigmatized, punished, and shamed, especially when sex occurs outside of what is considered normative. So pleasure and sex are prioritized for some people, not others. So there are marginalized sexualities and gender identities, including LGBTQ folks, racial identities, some practices such as sex work, some health conditions, HIV, where sex is more stigmatized than when it's among other people. And people have been talking about the importance of a trauma-informed sex-positive approach that can inform interaction, care, and practice with people. The second dimension, when we're thinking about strength-based approaches to HIV and STI, I really want us to think about intersectionality. And so I'm sure a lot of you have heard this term, and formally it was coined by Dr. Kimberly Crenshaw, but in the last 20 years, but even before that time, people were talking about the core concepts of intersectionality, such as the Combahee River Collective Statement. I do encourage, if you haven't read this, it's only 4 pages, read it. It's really a call to action by feminists, women of color. And they describe, we are actively committed to struggling against racial, sexual, heterosexual, and class oppression. We see as our particular task the development of integrated analysis and practice based on the fact that the major systems of oppression are interlocking, and the synthesis of these oppression creates the conditions of our lives. So intersectionality has become a really key way that we are approaching HIV stigma, first termed by Michelle Tracy Berger, the concept of intersectional stigma with women with HIV. On the right, you'll see a figure of intersectional stigma developed with colleagues, Dr. Mona Lutfi, Dr. Wangari Thoreau, among others, with Women's Community-Based Research Project. We're working in 5 cities and towns in Ontario with women living with HIV from very diverse backgrounds. Really, the emergence of these circles you see around sex work stigma, racism, homophobia, transphobia, sexism, and gender discrimination, and HIV stigma really shaped people's lives at the micro level, including intrapersonal, how people see themselves, interpersonal, how they connect with others, at the meso level, community and social norms and networks, at the macro level, so people's experiences and structures and institutions. However, on the left, you'll see what looks like a piece of pie. In the midst of these different kinds of stigma discrimination, women living with HIV still reported and demonstrated resilience, social solidarity and network building, and advocacy and challenging stigma. So it's not in spite of, it's because of experiences of multiple forms of stigma discrimination. There also emerges these strengths in solidarity and resistance. And that's a strength-focused approach that actually comes from these core tenets of intersectionality. And you'll see on the bottom left, I work with the NIH on HIV stigma conceptualizations, and in our special issue in BMC Medicine, we also talked about this movement towards looking at intersectional stigma, and within people who are multiple marginalized communities, there is these strengths and solidarities that exist that we can actually consider, look at, and work with and build on. And, you know, in stigma research, and particularly on HIV and STIs, we know we need to move beyond stigma approaches that are just looking at one health issue, that only look at an individual's processes, maybe their internalized stigma, to look at social and structural context. We have to conceptualize people as more than just a stigmatized person or a stigmatizer. And we also need to look at these intersecting health issues. This is a long quote, I'm not going to read it all, but Dr. Kimberly Crenshaw talks about that we often view race, gender, and other identities as negative, as something that will hold bias and reflect systems of domination. But she reminds us these identity categories can also be the source of social empowerment and reconstruction. So people don't necessarily need to get rid of HIV stigma or not HIV stigma. We need to get rid of HIV stigma. We don't need to get rid of HIV necessarily, you know, for people living with HIV, or get rid of race or gender. What we need to do is get rid of the stigma and discrimination attached to race and gender. And you can actually have pride movements. We can have Black Lives Matter movements. We can have LGBTQ pride. We can have celebrations of people living with HIV and in World AIDS Day and strengths and resiliencies. So we don't necessarily saying we're get rid of all social identities. We need to get rid of the oppression, but also look at the empowerment that also exists within communities that are experiencing marginalization. And this, looking at a history of community strengths, has a long, long history in HIV. You know, for decades, LGBTQ communities and allies have led activist, advocacy, mutual support, and collective care initiatives. In the article that you see here, which was recently published in the Journal of the International AIDS Society, I map various stigma processes and resistance processes across HIV, COVID-19, and MPOX stigma. And you see community strengths, you know, in the last year in the MPOX community-based responses and AIDS service organizations, LGBTQ community groups, sex worker organizations, where people are helping other people find out how to access the MPOX vaccine, providing social financial support, and even now pushing for global vaccine equity movements when it comes to MPOX vaccines. So looking and leveraging and growing community strengths in response to HIV and STIs has a decades-long history. And deficits approaches that only focus on risks in a community and disproportionate impacts of harm in a community run the risk of overlooking skills, knowledge, and the collective resources that always exist in a marginalized community. And HIV and STI prevention is more effective if it builds on and acknowledges existing resiliencies. You know, just one example, Dr. Trevor Hart, one of his studies, they looked at if you added the psychosocial strengths to a multivariable model of risk, the linkages between psychosocial problems such as substance use and condomless sex was no longer significant. This social support is something that is already existing in a community. So we just actually have to look at it as a protective factor and figure out how can interventions then grow and build on social support. And this is more of a sustainable approach to building intervention models if you're building on community strengths. So you can see the article referenced here. I was a co-editor of actually 2 stigma special issues last July for the International AIDS Conference. I wouldn't recommend doing 2 stigma special issues in the same month as a co-editor, but I did. One was on HIV stigma for the Journal of the International AIDS Society, and you can find some of our important work there. And then this was for an NIH special issue in the American Journal of Public Health. But this article by Tonya Petit and I, we really looked at what would it look like for a strength-based approaches to truly be integrated in HIV research. Another example, the African-American and Black Kiki and House and Ball community is over 50 years old, as often described in the literature as engaging people at high risk for HIV and STBBIs. But more strength-based approaches have looked at, well, actually participation in these communities is associated with resiliencies. And especially for a younger Black LGBTQ youth, is linked with executive functioning, social and emotional development, and physical and emotional safety, often in contexts where people may experience family or social, cultural, and institutional exclusion. So there are these community strengths that are naturally existing in grassroots movements already in communities that we can leverage in HIV and STI. There was a couple of special issues on resilience in HIV in 2018, one in AIDS and one in AIDS care. Our team contributed to one of those articles in AIDS care, where social ecological levels of resilience have been described. So including individual levels of resilience, like adaptive coping, interpersonal, social support, community, collective efficacy, and structural. And it's linked with ART adherence, antiretroviral adherence. But most studies that look at resilience look at it as an individual or maybe an interpersonal level variable versus at the community or structural levels. Our team conducted a scoping review recently of looking at all this quantitative intersectional stigma research and saying how many people looked at strength-based or empowerment-based variables in their intersectionality models. And we found that even though there's a potential to amplify this collective efficacy, solidarity, only 40% of studies looked at any strength-based factor, and most are on the interpersonal or individual level. Yet we know if we look at the community level, like social cohesion, efficacy, community connectedness, or structural level, activism, women-centered HIV care, that those are also strengths that can help people engage in HIV and STI care, prevention, and live better lives. So I just wanted to give 3 really brief case studies on strength-focused approaches. So this is led by Dr. Candace Liss at Foxy, Fostering Open Expression Among Youth. We've been working together, I think it's been 9 years now. I was actually just in the Northwest Territories last week at this very lodge, but trust me, it looks different in negative 28-degree weather. I did see the aurora, which was great. But what they did was they worked with and for youth, Northern and Indigenous youth in the Northwest Territories, to build on the strengths of Northernness. That's one of their values, Indigenous, rooted in Indigenous teachings and cultures, working with elders. The elder you see in the center top was there last week, Setsune, and using arts, teaching, drumming, to build youth's self-esteem, their knowledge around sexual health, their ability to discuss consent, and really learn how to engage in safer sex and healthy relationships for their life. And these are, some well-known we've documented these, other people have documented these as challenges rooted in, racial inequities, structural inequities, intergenerational trauma, especially experienced in a context such as NWT, which are the highest number of residential schools per capita in Canada. But, issues of food insecurity, substance use, depression, violence, and lower sexual relationship power, all social determinants of HIV and STBBIs that we have been trying to deal with, that we have been mapping as linked with safer sex efficacy, condom use, depression, and also the intersection with LGBTQ identities in rural locations where there's more confidentiality concerns really are social determinants of health. But we do apply this strength-focused, culturally grounded focus in interventions. There's 2 types of interventions. They do land and peer-based retreats at this fly-in lodge that we were at last week, and they also do school-based workshops. And we have documented positive outcomes of both on Northern Indigenous youth. So that's one example of working with the strengths of the community and culture and land to advance HIV and STI prevention. The second example is a project that I worked on in collaboration with the Black Coalition for AIDS Prevention, as well as the 519 community, where we worked with transgender women of color. I just want to shout out Yasmin Prasad at the 519, who is central to this. And we were intending to adapt an evidence-based CDC intervention for trans women of color in the US for Canada, but we were actually told, hey, stop, focus on me and what I want to be, focus on validating me. And so we were really called on by trans women of color in Toronto to focus on self-love, to focus on the strengths within people, within communities. And that's what we did. And, we used various arts-based methodologies, including affirmation cards. And, it's published in our articles that I shared earlier. But, this is just one example of a participant holding a mirror and reflecting on what they saw, saying, I saw an amazing person in the mirror who goes through a lot of shit in her life, and she's still standing. I saw the best person in the world in the mirror. So you're talking to a group of largely African, Black and Caribbean transgender women who are at disproportionate risk in many places in the world for HIV and other outcomes. But the community is saying you need to focus on building up our strengths and the way that we view ourselves. And we actually, in sharing these strengths with other members of the community, these are cards that trans women of color wrote for other trans women of color as messages of advice and support on the journey. So this more recently, we were in a special issue on methodological innovations, and we really focused on this methodology and this focusing on self-love and validating the strengths in people and communities as a method of critical hope in HIV research. And so you can find more about it there. And the final approach I just want to talk about is around using participatory methodologies such as comics. Been working for the last 10 years in Jamaica, and this is with a project with young LGBTQ and sex working folks living with HIV. And there's a lot of problems we documented here: intersecting stigma, HIV care barriers, isolation, and unmet material needs. And these are not new challenges facing people living with HIV, and particularly LGBTQ and sex working people living with HIV. But what could we do about this, and how could we actually engage people affected by HIV and stigma discrimination in envisioning how to live positively with HIV? So we took the qualitative data and, which was very powerful around stigma, around discrimination, around social isolation. And we created a comic book series, and the comic book series showed the HIV care cascade. This is from getting a diagnosis to taking medication and different medication barriers to finally living positively with HIV. And this is done in patois by the community partners in Jamaica, but these are various ways that people said how they live positively. People, went to a support group. People want to live positively. They know the benefits of medication. They want to look good. They want to live for their children, and they want to support other people living with HIV. So we actually use these comics in a blank version as an interview guide with people living with HIV. And this is just an example of what somebody wrote about when we asked them, how do you live positively? People express gratitude for having a home and a job and food, living in a community where they felt respected, and having a partner who knows their HIV status. So this is just some examples I wanted to share of ways that we can build on strengths that are existing within people, within their relationships, and within their communities, within their cultures, and within their context and their land, to integrate into HIV and STI programming. So getting to pleasure next. So what do we mean by sexual pleasure? So I don't know if anybody was in Mexico City for the World Association for Sexual Health Conference. I was actually there, which was great. And they created a declaration of sexual pleasure and describing sexual pleasure as the possibility of having pleasurable and safe sexual experiences free of discrimination, coercion, and violence, and how that's a fundamental part of sexual health and well-being. And it is actually grounded in having access to sexual rights. So equality, non-discrimination, autonomy, bodily integrity, and freedom of expression. So you can find this on their website, the Declaration on Sexual Pleasure. I'm not going to read all of this to you, but you can see this Declaration of Sexual Pleasure by the World Association Sexual Health talks about, as I mentioned, having pleasurable and safe sexual experiences, accessing sources of sexual pleasure is a part of the human experience. It's part of sexual rights. It acknowledges diverse sexual experiences. This part, which might be the most relevant to you, sexual pleasure shall be integrated into education, health promotion, and service delivery, research and advocacy in all parts of the world. And finally, the programmatic inclusion of sexual pleasure to meet individuals' needs, aspirations, and realities contributes to global health and sustainable development. And so I think that gives us all sort of some action points and some entry points into sexual pleasure work. And as I mentioned, it actually needs sexual rights, which refers to, human rights regarding sexuality and sexual health, protecting people's rights to fulfill and express their sexuality, enjoy sexual health in a framework where people are prevented or we're trying to eradicate discrimination. So I also really like this approach to sexual well-being. This is published by Mitchell et al. In the Lancet in 2021. What is sexual well-being and why does it matter for public health? And here you can see 4 concentric circles: sexual health, sexual pleasure, sexual well-being, and sexual justice. The sexual health, as we mentioned earlier, includes sexual violence prevention, STI prevention management, sexual function, sexual pleasure. I'm going to get into that definition next, but sexual well-being here includes sexual safety, sexual respect, sexual self-esteem, self-determination. And then you see sexual justice, which is around sexual rights and citizenship, and sex positive practice, which we've already spoken about. And so their definition of sexual pleasure in the sexual well-being framework is that it's grounded in physical and psychological satisfaction of sexual experience and these key enabling factors such as self-determination, consent, privacy, and confidence, and the ability to communicate and negotiate sexual relations. So this is what a lot of the work that our team does is around safer sex efficacy and people's confidence and skills around negotiating safer sex and navigating relationship power dynamics. And sexual pleasure here is described as being both event related, so around a sexual occasion, timing, use of protection methods, as well as person related. So what is the interpersonal dynamics, communication, negotiation, and trust? So what does the event look like, and what does the relationship with the persons involved look like? And I'm not going to repeat all of their wonderful article, but just if you want to learn more about how to think through comfort with sexuality, what that might look like, how to operationalize that, a lot of that also is around ease in discussing sexual anatomy with a health professional. So there's roles for all of you when you're thinking about sexual well-being and comfort with sexuality. And, the article delineates all of these different dimensions very nicely. I just put up as an example here, self-determination and sexual self-esteem. And so does this just really sound good? Does this really matter? Why should we care? We're here in our lunch or breakfast or wherever you are calling in from. Well, yeah, it does matter. So I've been thinking and writing a little bit about sexual pleasure and sexual rights as part of the Sustainable Development Goals, how these are really omitted in our Leave No One Behind agenda of sexual health. And sexual pleasure is actually the main motivation for people to engage in sex around the world. Sexual pleasure is one of the reasons why. There's other reasons, of course, but it is a motivating factor that is often overlooked when we're doing sexual health and STI and HIV prevention work. But when we actually integrate sexual pleasure into sexual health education and healthcare training, This is also there's been a special issue in the International Journal of Sexual Health on Sexual Pleasure. If you're interested to check that out, and this article by Ford is part of that special issue. It talks about how explicitly including sexual pleasure, it promotes sexual rights and sexual health, and it expands public health programming to address sexuality as a personal and social asset. So that's a strength-based perspective I was just talking about, rather than simply a health challenge to be prevented or resolved. And you would expect there'd be improved sexual health and well-being. Good news. There is a recent systematic review and meta-analysis of what is the added value of incorporating pleasure in sexual health interventions, where the authors found that in a meta-analysis of 8 studies, when sexual pleasure was integrated into HIV and STBBI risk reduction interventions, it was associated with increased condom use versus non-pleasure incorporating interventions. You can check this article out for more what exactly was included in these interventions, but from my reading, and just what I wanted to share briefly is this can include how condom use can be described and shared as fun and pleasurable. Pleasure in the context of behavioral skills such as lubrication and safer sex, eroticizing safer sex, confident in pride of one's bodies, affirming rights to pleasure. These are just some of the various strategies that were incorporated into these interventions. And, this is also important when we think about empowerment of marginalized communities. Youth, Michelle Fine and McClellan's work talks about this concept of thick desire. So having youth also imagine themselves as having agency and understanding what their desires are, what pleasure could look like, without only just focusing on the dangers of sexual health and having sex. So what does it mean if we actually let youth imagine themselves as sexual beings capable of pleasure and agency, rather than as just being fearful, especially when you're talking about maybe marginalized youth who have less power in relationships. And with women living with HIV, and this is the work from Chiwos and Ali Carter and Angela Kaida's work, looking at relationship dynamics with women living with HIV in Canada, higher levels of love, intimacy, and relationship power equity was actually associated with sexual satisfaction and pleasure among women with HIV. And conversely, sexual inactivity was linked with higher HIV stigma. So we see that sexual pleasure actually matters for everybody and needs to be thought of as part of an empowerment package when we're talking about marginalized communities. And this really briefly, because I know about 5 more minutes left. If you have not heard of the Pleasure Project, go to their website after this talk, of course, but they have amazing advocacy, educational, and resource tools for integrating sexual pleasure. One of our podcasts, we actually had one of the founders, Annie Philpott, on. She's just amazing, and they do a lot of advocacy. This is all available for free on their website. There's a trainer's guide for how to mix pleasure and prevention through various activities. They create these postcards at conferences, around sex, around sex toys and sexual pleasure. They've created a pleasure-based sexual health principles that different agencies can sign on to. And they have a global pleasure mapping project, which is really exciting. And they have pleasure advocates all around the world doing various things in their communities. So check out the Pleasure Project if you have not done that. There's also a really interesting article in this free training toolkit for healthcare providers and educators, linked with the same team that made this. It's called a Pleasure Meter. It's actually looks at sexual health, sexual rights, and sexual pleasure, and sexual history taking, counseling and education on HIV and STBBIs. These are all free online resources. And so the Pleasure Meter can be used to guide sexual history taking, counseling, education on HIV testing, STI testing, treatment, care, PrEP, condoms, uses motivational interviewing, and has 6 enabling key factors, which I'm going to show you. So this is all available for free online. The step 1 is, you have people think about their relationships and these dimensions and these rainbow colors around physical and psychological satisfaction, enjoyment, self-determination, consent, safety, privacy, confidence, and communication. And then you can create a diagram. And then they also have, questions where you can discuss all of these different factors with the client or the patient, the participant. And the third I'm going to briefly touch on is just the idea of sexting. So sexy, texting as a strategy for condom negotiation. This is some work by my colleague, Dr. Moses Akumu, who actually developed a scale to measure a sexting for condom use negotiation. And this is not, this was shown to be associated with sexting, knowing how to access condoms and being able to use sexting to negotiate condom use was linked with condom access, knowledge, and use. And other work has shown that adolescents have been using texting for safer sex, so safe sexting. So how can we think about, equipping young people and all ages of people with the ability to integrate pleasure into their safer sex practices, maybe through digital technologies? So I think there's just a lot of possibilities that we can explore. And so for the last few minutes, I wanted to just think about what would it mean and what are the steps for us all here today to think about creating or engaging in and growing sexual health enabling environments. I just have 5 last brief thoughts for your consideration. The first is moving beyond vulnerability and towards complexity. The second is reflection. The third is technical and transformative communication. The fourth is context. And the fifth is flourishing. These are just very brief thought snapshots of these ideas. So the first is just to move beyond this idea of vulnerability, or considering that certain groups of people are just vulnerable. This concept is vague, doesn't really look at how there's power being produced and who is not vulnerable. So, we should be thinking that no one is inherently vulnerable, and why are people vulnerable to what and how. And actually, just want to shout out Dr. Charlotte Lopi, who really has challenged a lot of my own work around kind of just categorizing, certain populations of youth, including Indigenous youth, as vulnerable, and just really not doing that, and instead thinking about how people might be marginalized socially, politically, et cetera. And also Dr. Eve Tuck has a really great article about moving beyond damage-centered research. And so she talks about a trend with research with Indigenous communities where people are kind of only documenting the effect of oppression. And she invites people to revision research, to not just document the harms of oppression, but to think about what are the long-term repercussions of communities thinking of themselves as broken or at risk. And she kind of conceptualizes this term of desire-based research frameworks that look at understanding complexity, contradiction, and the self-determination of lived lives. So I highly recommend looking at her work. The third point is around reflection, just for ourselves. Where are we confident in when it comes to sex and talking about sex? Where do we need more training, practice, and support? What biases might we have around sex and sex positivity? How can we unlearn some of these? And, just thinking about what are the opportunities you have right now, or you might have in the future, to integrate strengths and or pleasure-based approaches in the information and resources you provide to clients, sexual history taking, and how we provide counseling and care around HIV and STBBIs. And as I mentioned earlier, there's this free online training and toolkit, which is really, really great. I recommend checking out if you're interested. I think this is 4th. There's 5. I'm getting through them all, nearly there. Is thinking about communication beyond technical approaches. So there's technical communication where we give facts and we give skills, like here's some HIV stats, STI stats, here's how you use a condom correctly, this, here's PrEP, here's all your options for prevention, to thinking about transformative communication. So how do you give people communication that actually helps them take up the technical communication? And that's known as transformative, when people are empowered to actually take control of their own health. So this might build communication skills to be able to articulate what people need and want in relationships, or from a doctor, for instance, from a partner, and also creating a receptive social environment where these voices will be heard. So, understanding what are the drivers of HIV and STIs, and how can people be equipped with confidence, skills, advocacy to address these drivers. Okay, now we're at the second last one, as context, which is very related to that. So, our team has written a lot on context and the role context plays in shaping uptake of HIV testing, for instance. So symbolic contexts: are people treated with dignity, value, and respect when they're accessing care, when they're accessing HIV and STI information, resources, services? If they're not, people are obviously less likely to come. Do people have access to social support and some social capital that's empowering and allowing people to have conversations that might be challenging or to receive support? Do people have material resources to participate in healthcare? These are just different dimensions of context that are really important when we are expecting people to engage with HIV and STI prevention. And finally, a flourishing, which is a concept I'm really excited about. There's some coming out of BMJ Global Health articles on flourishing, some in social science and medicine, mental health. But flourishing is, in the dictionary term, is to grow luxuriantly, which I love that. And by Willen and all, they described flourishing as an active process of striving to live in keeping with one's defining values, commitments, and vision for the future as individuals and in the context of one's family and the communities to which one belongs. So may we all ourselves strive to live a life where we experience flourishing, but also the people we work with in the context of, HIV and STIs and the rest of their lives. So thank you. And I want to thank all the funders. There's CHR, SHIRK, CFI, Grant Challenges, Canada Research Chairs, all the team members, co-applicants, collaborators, peer researchers, participants. And you can check out my book that came out pretty recently in our podcast. And I'll stop sharing now. Thanks.
Thank you, Carmen, for such a great thought-provoking webinar. I have a few questions. There's a question about Me Too movement. I'm not careful. I'm not comfortable talking about pleasure in the practice. Would that be dangerous for my practice?
Is that a question for me?
Yeah.
Yeah.
Someone is asking, because of the Me Too movement, I think people fear asking questions about pleasure to be reported to the college of physician or nurses as appropriate.
So I think, one of the slides that I shared, let me get out of there so I can look at it, there was other facets that if you didn't want to directly talk about pleasure, you could talk about consent. You could talk about safety, privacy, confidence, self-determination, how free people were, and communication, negotiation. So if you are worried about going as far as sexual pleasure, remember how I said it's founded on sexual rights and self-determination. So you could, I think, say you're like, well, I don't really want to talk about if they're enjoying their sexual life, but I can talk about if they're experiencing safety, if they're having access to a relationship where they have consent over what they're doing, because that's all part of your sexual health. So I'd say, figure out where you feel confident and where you feel could fit into your own practice. So maybe if you're concerned about the sexual pleasure, on that pleasure meter, there's a bunch of other things that are not about pleasure. I mean, they're about more your sexual health generally. So how free did you feel to make choices? Did you consent? How safe do you feel in your relationship? How much privacy do you have in your relationship? How confident are you to express yourself with your partner? I think all of those are very realistic conversations you could have just around people's ability to share their own preferences. How would you rate the quality of your communication negotiation? I'm just reading these off of the pleasure meter. So yeah, so I think obviously, what will work best for you. You're all experts. So even if you just pick one thing out of this talk that might be useful, around consent, quality of communication, just even considering, am I like, feeling uncomfortable about having any of these conversations, or is there one thing I could do different in my practice? So yeah, don't go there if you're worried about getting in trouble, but there's other, as I said, it's grounded on so much of the foundation of just people being able to access general aspects of sexual health, because you cannot experience sexual pleasure if you're not able to give consent, if you're not able to communicate what your needs are. So you can start with more just the foundations of sexual rights.
There's a comment about people working with women in sex trade, feeling comfortable talking about stigma reduction, but not feeling comfortable discussing about pleasure.
I mean, that's a really good point. I think you could differentiate, between work and personal relationships. I've done some work with sex workers, and including in Canada with the Planned Parenthood Toronto. And what we found was there was an over focus in sex workers' experiences with the health profession on risk. So they would come in to talk about an earache and be given more STI tests. So everything came down to like sexual health. It's like, or any kind of mental health challenges were automatically attributed to their work, versus maybe childhood trauma or something else going on. So I mean, I think if there is positive discussions about sexual health happening, that is great. And also to acknowledge that people have relationships outside of work that, might also need to be discussed with what's their relationship power, their happiness, their consent, their communication style, their safety. And also, maybe for sex workers, there are other aspects in their life about joy and pleasure beyond sex, right? So you're right. Like you want to, maybe not just focus just on sex with a group who's so sexualized, but also to look at the nuances of the different kinds of relationships people have, and how a lot of those social ecological factors in their life are probably, might be the reason that they are there to speak to you. So it's not about forcing pleasure conversations on people. So, but it's about not either over sexualizing people or thinking they're just vectors of risk, which has generally been the messaging we heard from young sex workers, at least in Toronto, is that they don't even want to disclose that they're a sex worker because it's going to be on their file and they're always going to have to get tested. And they're usually the experts. Most of us are usually the expert in most areas of our life. And sex workers have been leaders in HIV and STI prevention. They have actually been leaders in safer sex and pleasure-based work for decades. So we probably have a lot to learn from sex workers when it comes to this work as well. So yeah, having the conversation, not stigmatizing folks. But you can still ask about safety and consent and the other aspects of their life too, and apply a strength-based approach. That is also a cognizant, like a strength-based approach could also be like exploring what stigma looks like in their life and how they're managing it. So, maybe people aren't disclosing to family, but they have friends they disclose to. Maybe, so a strength-based approach is looking at how people are using their own resources and collective resources and connection to community to sort of mitigate stigma. So, maybe you want to focus more on the strength-focused approach versus the pleasure-focused approach.
Thank you. I just want to remind people that if they have questions, they can put in the Q&A box. And in the Q&A box, there's the website to reach the Pleasure Meter site if you're interested. I think there's a lot of things in that website.
Yeah, I just discovered it. I've been using the Pleasure Meter, as a resource. But then for you today, I just kind of I was like, I want the actual tool, and it's in this web link. So I just provided the web link because that's where you can actually download the tool if you wanted to look at any of these as being conversation starters with your clients or the people you're working with. So I can't verify everything on these sites. I just thought they'd be useful. Use them at your own discretion. Take what's helpful, leave the rest.
there's a comment about religion and interference with the sex ed program. Do you have any suggestion how to prevent religious authorities to block program like in school or in communities?
So I was actually one of the expert witnesses. Remember in Ontario a few years ago, they were trying to change the sexual health curriculum. I'm trying to block out that experience because it was so horrible being like, having to be like, cross-examined. But what I think, if we base it on health as the main outcome, and that, when it comes to Foxy, we're always doing things that are age appropriate, so for the younger kids, we're talking just about consent around your body. We're talking about understanding how your body works. If we don't know how our body works, if we don't know how to tell people we don't want to be touched this way, or we want to be touched this way, then we're actually like putting all people at risk for abuse, right? For unhealthy relationships. And so I think if we bring it back to number one, telling people who might have problems due to religious, social, cultural beliefs, that everything is done in an age appropriate manner. So how you might talk to a child about being touched in ways that they want or they don't want to be touched, we would do things in an age appropriate manner and be realistic. And also, secondly, it is about health. So if we kind of try to just focus on, well, actually, people need to know how to manage menstruation. People need to know how ovulation works. Boys need to know how their body works and what puberty is going to look like. So it's actually just part of our health. And then the idea around part of your rights is around violence prevention, right? So I think I actually like the way that the sexual health conceptualization of the WHO includes sexual and gender-based violence prevention, because no matter what people want to argue with whatever religion's part of sexual health is actually understanding consent, preventing violence, and not many people argue with you about that. So I think you could talk about health in general if you don't want to say sexual health, but know that sexual and gender-based violence is in their healthy relationships. So a lot of what we focus on with Foxy, from 12 to 17, not all of them are sexually active, especially the younger ones, but we actually talk about how to identify what is a healthy relationship and not a healthy relationship, how to communicate what your needs are, how to build your own confidence in who you are, and how to use your voice. So these are all things that are part of this kind of quote sexual health education that are very age appropriate. So we really have to communicate a lot with parents, like not me directly, but Candace and Foxy team are always in these conversations with parents around, we're not telling kids to go out and have sex. Or telling people this is what your body is. This is how you have control over your body. These are, some of the, the ways to communicate about what you need. These are some of the consequences around HIV and STIs, but a lot of it is around having agency over your body. And I think that kind of the idea about people wanting to have healthy relationships and be free from violence could be maybe a way to counteract some religious challenges. I don't know. It's not easy though. I think it's and it's not going away, and it's getting worse. So I think we are having to prepare ourselves for how to have these conversations in an increasingly extreme environment where a lot of, like abortion rights in the US are under attack, right? So like we're moving in a way that is a lot more conservative and traditional, I think, than maybe we have in decades. So it's very strange.
You talk about the WHO sexual health definition. Is it still a work definition, or it's been accepted now?
No, it's definitely a working definition for sure.
Since 2017.
Yeah, so the operational definition, the working definition. I don't think I'm part of the guideline development on self-care for sexual and reproductive health and rights. And there's so much negotiation that has to happen for a new definition. So I think you're right. It's still a working definition. I like it though. I'm working it. I'm making it my definition. At least it's the operational definition as of now. Because I just like how comprehensive it is, and it gives us a lot of ways into sexual health work.
And do you think that having free contraception, as is now the case in BC, will give more complication with sexuality, like more STIs and more violence? Some people are against free contraception because it looks like it's encouraging people to be sexually active.
I believe in free access to all prevention technologies. I don't think that the provision of, this has been a long debate in the field of harm reduction. So if we provide, safe supplies of needles or crack kits, well, nobody is going to start using drugs because they got a needle. Oh, great. I think I'm going to do something with this. No one is going to start using contraception. No one's going to start having sex because there's contraception available. I think it's really reduces access barriers, and is so important. So it's just so important now. I believe in giving free access to condoms. Free access to contraception is great. I don't think there's any research that shows that increasing access to reproductive health technology is harmful. It's usually the reverse, that people might not have enough money to get it, or it's complicated, a lot of hoops to jump through to get it. And so it's usually a barrier. Like economics is usually a barrier to accessing contraception. And you think about who is impacted. Well, it's people living in poverty, it's people experiencing homelessness, it's young people. So people will not start having sex because they can get a pill. They're already having sex, and don't we want them to have all the tools they need so that they can use them, to live a healthy life? So, I think especially these days, with all these rights constraints, just anything we can to support people to be healthy and to have more control over their bodily autonomy is good. I've never seen anything that says free contraception, produces violence. It's usually violence, and being in a violent relationship constrains access to economic resources, say among women, and then they might not be able to afford to go and even pay a copay for, contraception. So it's usually, so they're the ones who are impacted by needing to sort of find the resources. So I think free contraception for everybody. I'll sit on that. I'll sit on that soapbox. Go for it. Yes.
It's all the time we had, Carmen. We could have gotten an extra coffee and have a lengthy discussion this afternoon. So maybe we'll have you back on this issue a little bit later. So thank you very much, Carmen, for your generosity in providing your expertise on this topic. So
thank you for having me.
Thank you all for being with us. Thank you, Greg and the CPHA people, for providing the support to this USTI Canada webinar. And I invite you for the 5th of April. It's going to be a webinar about PrEP. And it will be given by Dr. Daryl Tan from Toronto. And Daryl was one of the 3 authors of a CMAJ article reviewing PrEP in Canada and its underuse. So join us on the 5th of April for the PrEP webinar. So thank you all for being there, and I hope to see you on the 5th of April webinar. Thank you again, Carmen.